Good morning. I'd like to welcome everybody to Medicine Grand Rounds. This is Global Health Week, and I'm delighted to be introducing one of the leaders in global health research in the Department of Medicine at Washington University, Dr. Victor Dávila-Román. Dr. Dávila-Román received his medical degree from the University of Puerto Rico, and then after a little bit of time came to what was then Jewish Hospital for his internal medicine and cardiovascular disease training, and then joined the faculty where he has been for almost the last 30 years, so all of his academic career. And over that period of time, he has become really one of the leading national and international experts on cardiovascular disease as a global challenge. And for those of you who don't know much about global health, infectious diseases have always been the major threat, but increasingly non-communicable diseases, particularly cardiovascular disease, have become the leading cause of death, of premature death, in worldwide, and particularly in low to middle income countries. Currently, Victor is co-director of the Global Health Center. Global Health Center is a jointly supported by the Institute for Public Health and the Department of Medicine. And Victor also serves as the vice chair for global health in the Department of Medicine. And I'm delighted to, as I said, to welcome him. He's going to talk to you on the challenges and opportunities for cardiovascular research in global health. Victor.
Thank you, Will, for that generous introduction, and good morning, everybody. We go here. It is a pleasure to be here today for Department of Medicine Grand Rounds. Every year in late fall, the Department of Medicine Grand Rounds occur during Global Health Week, as Bill said, as part of a university-wide event that brings together Washington University and the St. Louis community to engage around global health topics. We have had a great week with simulating presentations and participation by students and faculty from across the university. My disclosures. My presentation today will provide an overview of three major topics, including global burden of cardiovascular disease, focusing on hypertension and heart failure, implementation science in global health, and finally, I will discuss opportunities for global to local health research, training, and capacity building. I will start with a case presentation of a 52-year-old woman referred to a tertiary hospital in a low and middle income country with progressive dyspnea on exertion, fatigue, palpitations, and lower extremity swelling. Her past medical history was significant for preeclampsia 30 years ago, and hypertension since then, treated on and off with a diuretic, which she most of the time did not take. She was obese, she was in AFib, her blood pressure was very high, her lung exam showed diffuse crackles, her cardiovascular exam was relatively normal, and she had lower extremity edema. This is her chest X-ray and admission in the emergency department, which was read, I think, appropriately as pulmonary congestion compatible with pulmonary edema. Her serum BNP levels were slightly elevated. The transthoracic echo performed 2 days after admission when she was already in sinus rhythm, showed normal LV size and function, an EF of approximately 60%, marked concentric LVH. And here you can see the walls of the ventricle over 2 centimeters. Normally, they are less than 1 centimeter. She also had normal right ventricular size and function. The Doppler echo showed a PAC systolic pressure estimated of 45 millimeters of mercury. That's compatible with mild pulmonary hypertension. Diastolic function was compatible with a grade 2 left ventricular diastolic dysfunction and that's characterized by impaired left ventricular relaxation as shown on the Doppler findings here on this side, and increased left atrial pressure. This is a clinical presentation, and transthoracic echo findings are compatible with the diagnosis of heart failure with preserved ejection fraction, or HFpEF. In an attempt to facilitate diagnosis of HFpEF, scores and diagnostic algorithms have been proposed. The H2FPEF score relies on clinical characteristics and TTE to discriminate HFpEF in patients presenting with unexplained dyspnea. Based on this score, our patient had a score of 8 of a total maximum 9 points, giving a probability greater than 95% of a diagnosis of HFpEF. Of note, elevated BNP levels did not add incremental information to clinical variables and TE for HFpEF in this particular study. A diagnosis of HFpEF seems highly likely for a patient based on these criteria. I will return to the case later. Going to talk a little bit now about the global burden of cardiovascular disease. On the left panel, we show data from the United States showing cardiovascular disease as the leading cause of death, not only in high-income countries like the US, but also globally, and particularly in low and middle-income countries. In 2019, over 874,000 people died of cardiovascular disease, with coronary heart disease being the leading cause of death, followed by stroke, high blood pressure, and heart failure. Cardiovascular disease claims more lives this year than cancer and chronic lung disease combined. Cardiovascular disease has also been the leading cause of death, not only globally, but also in low and middle-income countries, accounting for about 15 million deaths in 2019, a number that is expected to grow to greater than 22 million by 2030. Globally, 4 out of 5 cardiovascular deaths are due to heart attacks and strokes. Importantly, and as Bill alluded at the beginning, in low and middle-income countries, the clinical manifestations of cardiovascular disease occur at a younger age compared to high-income countries. As many of those suffering from cardiovascular disease are young people in their prime years of productivity, they now become a burden not only to their families, but to society in general. All these statistics are, of course, prior to COVID. In one of the largest studies of the cardiovascular effects of COVID, Dr. Al Alif from St. Louis VA Medical Center in Washington compared the medical records of veterans from 3 patient groups: those with acute COVID-19, 150,000 patients, uninfected contemporary control group, greater than 5.6 million, and a historical control group of 5, greater than 5.8 million, a pre-pandemic group comparison. Among those who were admitted to the ICU with acute COVID, they showed significantly higher cardiovascular conditions occurring in the following year, including myocarditis and pulmonary embolism. Even those who had a mild infection and not hospitalized had increased risk of heart attacks and other major cardiovascular events. This concurrent epidemic of cardiovascular disease and COVID-19 in the setting of global disparities and climate change represent the perfect storm for global increase in cardiovascular disease, morbidity, and mortality. Although cardiovascular disease mortality has declined over the last 30 years, recent studies suggest a plateau in total cardiovascular disease-related mortality and in coronary heart disease-related mortality, with rates of decline slowing considerably beginning in 2011 from about a negative 3.8 for total CVD to less than negative 1% annualized rate since 2011. This plateau in total cardiovascular mortality rates may be explained, at least in part, by increased hypertension and heart failure mortality rates. For example, the age-adjusted mortality rate from heart failure increased by 20% from 2011 to 2016, with mortality rates for both hypertension and heart failure increasing since 2011. The trends for heart failure and hypertension for Black men are particularly concerning. Hypertension-related deaths are also increasing at a much higher rate for those living in rural compared to urban areas, suggesting that the increased mortality from hypertension and heart failure may explain, at least in part, the increased cardiovascular mortality rates observed since 2011. High blood pressure has been the leading risk factor for death and disability globally for a long time. And in 2012 was responsible for about 7% of the global burden of disease. Recent data, also from the Global Burden of Disease study, published more recently in 2020, shows annualized rate of change over the 9 period ending in 2019, increasing by more than 5% per year for high blood pressure, high fasting, plasma glucose, and high BMI. These disturbing trends suggest that hypertension-related mortality rates are likely to continue to increase. The shifting global burden of hypertension will have devastating consequences in low and middle-income countries, both in terms of morbidity and mortality. By 2025, it is predicted that the prevalence of hypertension will exceed 1.5 billion adults, with the highest prevalence of hypertension occurring in low and middle-income countries, where approximately 75% of the world's hypertensive will live, representing an increasing unmet healthcare gap and an opportunity for research. A few examples of the hypertension prevalence increases in sub-Saharan Africa are illustrative. Take Nigeria, for example, with 218 million people, the largest population in Africa and the 6th largest in the world, with a mean age of 18 years, a very young population. While studies in the early 2000s showed prevalence rates for hypertension in the range of 15 to 20%, more recent studies from around 2012 show prevalence rates in the 29 to 45% range. In rural Rwanda, a recent study by our team showed prevalence rates of hypertension of 21%, which is higher than previously reported prevalence rates of 15% in 2013. Finally, hypertension awareness, treatment, control rates are very low, both in Nigeria and Rwanda, as well as in other low and middle-income countries. The transition from hypertension to 2 major intermediate phenotypes, left ventricular hypertrophy and left ventricular diastolic dysfunction, both of which were present in our case report patient, represent a major risk for development of the clinical syndrome of heart failure, resulting from either systolic and/or diastolic dysfunction, also known as HFrEF, or heart failure with reduced ejection fraction, and HFpEF, as in our patient. A recent IMPRESS report from the Haiti cardiovascular disease cohort further illustrates these issues. This study comprised of more than 2,900 subjects who had clinical heart failure by Framingham criteria. Their median age was 40, and 58% were women. At a median follow-up of 15.4 months, the all prevalence of clinical heart failure was 3.1%, with a mean age for the heart failure group of 57 years. The figure on the right shows the increased prevalence of heart failure occurring with increasing age from 0.8% in the 18 to 29-year age group to 11.2 for those older than 70 years. A statistically significant difference for linear trends across groups. HFpEF was the most common heart failure subtype, occurring in 71% of the cases. 1-year mortality rates for heart failure patient was 6.6% compared with only 0.8 for the no heart failure patients. A statistically significant difference. Several findings from this study are worth highlighting. Number one, age standardized prevalence of 3.2% is 5-fold higher compared to the current low and middle income country heart failure modeling estimates. These are the estimates that are done by different agencies to estimate the prevalence of heart failure in the country. So they're grossly underestimated. And it's also 50% higher than the prevalence in high income countries. Heart failure occurred 2 decades early compared to high income countries, 57 years versus 77. Heart failure prevalence was also greater in women compared to men. HFpEF was the most common subtype of heart failure at 71%, a finding that has already been shown in high-income countries and documented for the first time in a low-income country. The study also underscores that population-based estimates are needed to provide accurate data, heart failure, prevalence, age of onset, subtypes, and risk factors, and that heart failure is under-recognized in low and middle-income countries. I will now pivot briefly to discuss implementation science for global health research. A very low fraction of discovery science reaches patients in clinical practice. Recognizing that it takes an average of 17 years for new scientific discoveries to enter day-to-day clinical practice, and that only 14% of research reaches long-term quality health care, the NIH and many of its institutes, including the National Heart, Lung, and Blood Institute, have placed implementation science as one of their major strategic objectives, to improve health and reduce disease. Implementation science is the study of methods to promote integration of research findings and evidence into healthcare policy and practice to improve healthcare of populations. Implementation science studies represent the last stage of research in the science to practice continuum, preceded by pilot studies, early efficacy trials, and effectiveness studies that are distinct from and address different questions. Distinct phases exist within D&I defined by adaptation, implementation, sustainability, and scalability. There are 3 types of implementation study designs that vary based on whether their primary focus is on clinical effectiveness versus implementation outcomes, as shown on the table. A hybrid type 1 study design focuses primarily on effectiveness outcomes of a clinical or a prevention intervention, while also exploring implementation of the intervention as a secondary aim. A hybrid type 2 study design has a dual focus of both effectiveness and implementation outcomes, typically as co-primary aims. A hybrid type 3 study design focuses primarily on implementation outcomes, while also collecting effectiveness outcomes as these relate to uptake and/or fidelity of the intervention. Implementation science research also requires strategic partnerships with key stakeholders, many of which are listed on the slide. These partnerships are essential to the success of the projects. I will now talk a little bit about our specific program in hypertension and hypertensive disorders of pregnancy and heart failure. Our global health team has leveraged NIH funding opportunities to conduct implementation science research and training in these areas of hypertension, hypertensive disorders of pregnancy, and heart failure in low and middle income countries, where we currently manage a combined grant budget portfolio nearing $30 million of funding. I briefly describe some of these projects next. Hypertension is the leading risk factor for cardiovascular disease in Peru, as it is in many low and middle income countries. From the Peru NHLBI funded epidemiologic chronic study, we gather important information regarding prevalence rates in the country for hypertension, which range from 18.5 in people younger than 55 years and increases to 25% for those aged 65 years and older. Of these, more than 50% are undiagnosed and more than 70% have uncontrolled hypertension. Peru suffers from significant health inequities due to between rural and urban populations with limited resources such as healthcare facilities, physicians, and other healthcare personnel. Our ongoing ANDES study addresses some of these issues. The study setting is in Peru, PUNO, Peru, located at 12,500 feet above sea level on the shores of Lake Titicaca in southern Peru. On the right, you can see my pulse oximeter showing an oxygen saturation of 83% immediately upon deplaning and accompanied by a feeling of breathlessness. I felt like I was in heart failure. The population of PUNO is about 1.2 million, spread across 4 large rural districts. 72% of the population is indigenous, comprised of Quechua and Aymaras. A large proportion of households use biomass fuels for heating and cooking, producing high levels of household air pollution, another contributor to cardiopulmonary disease. The public MINSA, or Ministry of Salud, Ministerio de Salud, and the work-related Salud are the major healthcare system covering about 90% of the population. Our ANDES study is a UG3, UH3 milestone-based 2-phase program. The initial 2-year UG3 phase comprises formative work to set up the program, secure stakeholder involvement, and conduct a pilot study that will inform the subsequent UH3 phase randomized controlled trial through the use of implementation science methods. The ANDES UH3 phase is a hybrid type 3 randomized controlled trial aimed at assessing the impact of a community health worker-led multi-component intervention to evaluate and treat hypertension in this low-income indigenous community in PUNO. The multi-component intervention includes the identification of current and new hypertensive subjects through health fair and healthcare clinics, and the home service delivery by community health workers trained to engage in visits for blood pressure evaluation, monitoring, medication delivery, training of patients regarding cardiovascular risk factor modification, including compliance with diets low in salt and sugars, and to facilitate coordination with healthcare facilities. The control group undergoes usual care. I'm going to switch gears to another project. Our Global Health Center co-director, Mark Hoffman, who is on the audience, is leading 2 large hypertension-related studies in Nigeria. The Transforming Hypertension Management in Nigeria is an R01 project evaluating the effectiveness of a large-scale, multi-level health system intervention for improving blood pressure, awareness, treatment, and control across 60 primary healthcare centers in Abuja, Nigeria. The study has already shown impressive results with significant engagement in hypertension care and blood pressure control for over 16,000 patients, showing monthly blood pressure control rates increasing from 20 to 52%, a remarkable progress. The evaluation of Nigeria's National Sodium Reduction Program is evaluating implementation and scale-up of Nigeria's National Sodium Reduction Program through stakeholder interviews, population surveys, and retail surveys using a hybrid type 3 study design. As global health focuses on the health of communities, particularly those in low resource settings, in this sense, the bidirectional global to local concept aligns well with our Global Health Center emerging strategic vision of working in both global and local communities to improve their health. I'm going to switch gears one more time, and I'll put it all together at the end. Cardiovascular disease is the leading cause of maternal morbidity and mortality in the US and globally, accounting for about 1 in 4 deaths. 4 key factors are related to maternal cardiovascular mortality: race and ethnicity, older age, hypertensive disorders of pregnancy, and obesity. On the right side, you'll see work from our own group at WashU that recently reported an analysis of a large administrative data set capturing delivery hospitalizations in New York and Florida over an 8-year period that included more than 2.5 million women, of which 5% had preeclampsia or eclampsia during the pregnancy. At a median follow-up of 6 years, preeclampsia was associated with a 2-fold increase in the risk of a HFpEF hospitalization. Furthermore, the mean age at HFpEF hospitalization was 34 years, and median time from delivery to HFpEF diagnosis was only 32 months. Just picture this. You have a baby today, and you're hospitalized with heart failure within 2.5 years. This is a devastating complication and one that is totally preventable. This brings us back to our case report and the importance of early postpartum and lifelong follow-up of women with hypertensive disorders of pregnancy. The Enhancing Cardiovascular Health Equity in Mothers and Children Through Home Visiting, or ENRICH study, deals exactly with the challenge of cardiovascular disease prevention in pregnancy. Dr. Deborah Hare-Joshua from Brown School and colleagues have shown the effectiveness of the healthy eating and active living taught at home, or health intervention, which is an at-home visiting program promoting healthy weight during pregnancy and postpartum. ENRICH is a type 1 cluster randomized trial of the effectiveness of the health intervention in pregnant women right here in St. Louis, who are at increased risk of cardiovascular disease, and also their children. The AHA's Life Essential Aid scores will be used to assess maternal cardiovascular health. Some of our collaborating investigators are shown. Shortly after we got the ENRICH study funded, this RFA from NHLBI came out with the opportunity to conduct implementation science research during critical life stages and cretans transition periods in low and middle income countries. Based on our extensive research collaboration in Nigeria, a country that has one of the highest mortality rates for maternal death in the world, mostly related to hypertensive disorder of pregnancy, we could not think of a better opportunity to implement the health intervention program. The Enhanced CVA study is a hybrid type 2 cluster randomized trial to be performed in Nigerian primary healthcare centers to implement an adapted health intervention in women recruited during the antenatal period and their born children. We recently received funding for this project from the McDonald International Academy, as the study represents a great example of the local to global health connections that are so important to improve health on a global scale. Switching gears again, staying local. The Quartet USA is an RCT to test the effect of a 4 blood pressure lowering drug combination at quarter dose, also called 4/4, versus a single drug at standard dose in a federally qualified health center network in Chicago. The current hypertension treatment paradigm relies on adding and titrating a single drug at a time. This is a strategy that has failed both in the US and low and middle income countries, where hypertension control rates are low, 50% or less in the US, 20% or less in low and middle income countries. The Quartet strategy may result in new treatment paradigms that will be explored in several of our global health settings in the near future. Through the Fogarty D71 and D43 training grant programs and other, we have been mentoring, training, and building capacity in hypertension, HIV, and implementation science in Rwanda, Nigeria, Zambia, and Peru for the past 8 years. These programs have trained well over 60 individuals, resulting in master's and doctorate degrees and in multiple research projects led by the trainees. One example of this training program is the Data Science for Health Discovery and Innovation in Africa, or DSI Africa, a $70 million NIH Common Fund initiative started in 2021. Under coordination by our Global Health Center, Philippine and I were able to recruit, secure participation of a 19-member multidisciplinary team from 3 schools at WashU, including people with expertise in data science and computer science, bioinformatics, biostatistics, implementation science, public health, medical ethics, and others, in collaboration with partners at the University of Rwanda and the African Institute of Mathematical Sciences, also in Kigali, Rwanda, and the Rwandan Ministry of Health. Writing these collaborative grants in research for institutions is a challenge on many levels. At the Global Health Center, we believe that we are playing a critically important role in leveraging these training grants to train the next generation of low and middle income country researchers. Thanks to the leadership of Dr. Fraser in the Department of Medicine and Dr. Powderly at the Institute for Public Health, and Division Chief Dr. Prabhu in cardiology, Dr. Ivanov in general medical sciences, and Dr. DiPersio in oncology, we have successfully co-recruited some of the most talented and promising junior investigators in global health. The global health leadership has begun regular meetings with these early stage investigators to create a community, provide support, and enhance multidisciplinary collaborations. I will very briefly highlight the work of 3 of our early stage investigators. Dr. Anuba Agarwal, who's in the audience, has a K99 R00 grant that has the objective of shifting HFrEF management from multi-drug therapy with a typical sequential initiation and titration strategy to a polypill strategy containing guideline-directed medical therapy. This study will be a hybrid type 1 multi-center randomized control study in India, testing the effectiveness of HFrEF treatment with a polypill versus usual care on the composite rate of cardiovascular disease mortality and heart failure hospitalizations at 12 months. The potential impact of this project has huge implications for the treatment of heart failure worldwide. Dr. Lindsay Underhill, who's also in the audience, is working with our Andes team in Peru to understand and improve hypertension health service accessibility using geographic information systems, or GIS. Dr. Underhill used geocoded healthcare facility, road network, and population density data to construct maps that provide travel time estimates to the closest healthcare facility, showing that 56% of the population lives within 10 minutes from a healthcare facility, and 92% of the population live within 1 hour. Additional work in this area will map out different services offered at healthcare facilities so that patients will know exactly where to go to receive their care. She has submitted recently a KO1 for this work. Dr. Zainab Mahmood, one of our former cardiology fellows, has been awarded an ACC Merck Fellowship to conduct formative research evaluating implementation outcomes such as feasibility and acceptability of a home blood pressure monitoring program in postpartum patients with hypertensive disorders of pregnancy in Nigeria, where she's currently doing her work. This study also has important implications for the care of pregnant patients with cardiovascular disease around the world. I want to talk briefly about some of the opportunities with the Global Health Center that hopefully many of you will want to participate. Every year we celebrate Global Health Week, and that's why we're here today. We also are planning a Global Health Annual Conference in March of 30 and 31 of 2023, combined one day at the Danforth campus and one day at the Medicine campus, and hope that many of you will join us. We also have an annual summer research program that includes 3 tracks for students, undergraduate and college students. If you know any students in those positions, let us know. We'd love to have them. Our Global Health Works in Progress series meets every 4th Monday for 1 hour. People present their ongoing research projects and get feedback from a group of very expert global health workers that are always on these calls. The Global Health Week, Global Health Early Investigator Program, as I said, we're meeting with the faculty every 2 months, and probably we'll start meeting a little bit more often than that. There's also a Women in Global Health Midwest chapter. Those of you interested may want to join. A Global Health Student Advisory Committee. And finally, we have a Global Health McDonald Academy seed funding application program with $25,000 projects that are due in November 15 for those of you who may be interested. In the last month, we have assembled also an outstanding internal advisory board, which is highly representative of the university and their multidisciplinary interest in global health. The advisory board will provide insights with global health strategic planning, including identifying key strategic areas, increasing cross-campus collaborations, and building sustainable network connecting with global partners. I want to circle back to our case. This woman clearly had a diagnosis of HFpEF. Her hospital course. She received diuretics, antihypertensives, and beta blockers. She improved significantly upon discharge, losing significant amount of water weight. She was in sinus rhythm, blood pressure better controlled, lungs improved, and she had no edema. 5 take-home points from today. Number 1, cardiovascular disease is the #1 cause of morbidity and mortality in the US, globally, and particularly in low and middle income countries. There's an ongoing epidemic of hypertension and heart failure that is already here in the US and also globally. There's a lot of work to be done in these areas and a lot of opportunities. Low and middle income countries carry a disproportionate burden of cardiovascular disease, and this is likely to get worse in the years to come. Implementation science provides a powerful framework for robust uptakes of evidence-based interventions. And there are many opportunities for this global to local health research, training, and capacity building, and I will like to ask you all to join us in these efforts. I want to take this opportunity to thank all of you for your attention and also thank all our collaborators. Thank you very much.
I think I know we have time for questions. So I'm more than happy to take questions either from the audience or presumably somebody will tell me about questions from the Zoom audience as well, if there are any. Victor, we have a question up here.
You brought up about hypertension, treating it with 4 medications of low doses. In primary care, one of the biggest issues we see is polypharmacy, people wanting to decrease their costs, decrease their pill burden. And so thinking about using 4 low-dose medications, that seems like the opposite of what a lot of my patients are looking for. I wonder if you can kind of speak to that and then try.
It's a very good question, and I'm going to ask Mark Hoffman, who's in the audience and the lead author on that work, to answer the question. Mark.
These are ultra low doses, like more than 1.5. So you're getting that balance between efficacy and tolerability. Because for my patients too, I mean, they want to squeeze pills in their mouth every day.
Absolutely.
And they want to squeeze side effects and tolerance. So by having that, your dose side effect relationship is actually a lot linear. You get most of your blood pressure lowering effects in very low doses, but you minimize side effects. And then I don't get who the respond with what class.
Do you feel pushback though from now I have to buy 4 different pills?
No, it's one.
Oh, they free.
One pill. Yes. Yeah. Thank you.
Victor.
Yes.
That was a great talk.
Thank you.
So the increase in hypertension seems incredibly impressive. So how much of that is related to adoption of Western lifestyles and diet changes? And do you need to get at some of these fundamental interventions further also?
Yeah, very good question. Thank you, Vicky. The question is, do this increase in hypertension, does it have anything to do with lifestyle changes and dietary habits? And the answer is absolutely yes, 100%. So as diets become more westernized in all of these low and middle income countries, we're seeing increasing rates of hypertension, diabetes, obesity. You know, it's all of these comorbid conditions that really create the milieu for development of hypertension. And absolutely correct that dietary habits need to be changed, and that's very challenging. As Mark will probably attest, in Nigeria, trying to change the sodium consumption habits, it's a big challenge. Mark, you want to say any comments on that?
Well, it's the first time in human history that there have been more overweight than underweight individuals in the world. So it's like a huge new problem. And no country has reversed obesity epidemic. None. So nobody's got this cry. But it probably needs to be a reimagination of just how food is grown and manufactured and distributed and consumed. But food is very political. And so, you know, we're academics who often do the technical scientific work and help policymakers make decisions. But it's not, I think it's more of a collective decision on what are we going to do about food. And obviously starting earlier, so that's why we're doing pregnant women, risk factors, and kids, like that seems to be an area where there's increasing importance. Because we sort of think it's going to work better to start early. But it's a huge.
So Victor, one of the things you commented on, but I thought you might expand a little bit, is the importance of having partnerships internationally, but also growing capacity internationally so that the research is not entirely US centric or led by US so that we don't have a new form of colonialism.
Yeah, that's a very good comment, Bill. It's absolutely essential that we work with local investigators, and in most of our programs, if not all of them, we always deal with academic institutions, people who are committed to doing research. We work with them on capacity building and training, and they are co-investigators, multiple PIs on all our projects. So it's essential to get the locals involved in this, and it's also essential to get buy-in from the ministries of health, the hospitals, and the healthcare clinics. And every time we travel there, that's one of the first things we do is we go and meet with these people at all different levels. Stakeholder involvement is absolutely essential in this type of work. If they don't have the buy-in, we don't have their buy-in, the project is going nowhere.
Okay.
Inevitably, I have a point-out question. I guess I would point out that while we arbitrarily assign a BMI of 25 would be overweight, I would hold everyone a BMI of 23, probably pushing it to the which I know is depressing, but I think it's pretty arbitrarily go 25 and everything can jail at 25. And it's not. We focus on treating the obesity, but we really don't focus so much on preventing it in the first place, or promoting weight stability. And so I'm curious, I know you and I have talked about this a lot before, but how working with non-governmental associations is much easier for this, they're more nimble, they can achieve things. I wonder how you balance the limited reach of those groups with trying to achieve policy change within the country.
Yeah, that's a very good question, Dominic. How to balance the working with governmental organizations that are slow in react and balancing that with also working with NGOs. And the answer is really you have to work with all of them. The NGOs are usually local organizations that are, you know, they know the people in government and they are used to working with them. But you really have to push the agenda for both, and they have to definitely be both part of the conversation. Anuba.
Thank you, Mr. Phenomenal.
Thank you.
In your positions of leadership at the center department, I'd love to hear your vision for the future of the health at Rosh, some of the research capacity.
Yeah, so the question is, what is the vision for the Global Health Center for research and capacity building? So you know that we are right now at a very critical point at the university where the Board of Trustees have approved a School of Public Health. And so I think that the Global Health Center, you know, will hopefully become bigger and greater within that context. But we definitely have to work, you know, across departments and schools to develop a very strong program, just like we're doing to achieve those goals. Definitely, we need more infrastructure. We need more help with, you know, doing the work that we're doing, but we're getting there one step at a time.
Any other questions or comments? I think, you know, just to summarize, Victor, I mean, you've shown very, very clearly that there, from a research perspective for young faculty who want to make a difference, they can make a difference locally or they can make a difference globally, or they can do both, because it's very clear that global work has lessons and implications for the treatment of our own communities, particularly those that suffer from disparities. I think you've also shown that this is going to be an ongoing opportunity for NIH funding, and I think that's absolutely true. So I would strongly encourage anybody listening who's interested in the potential for taking their work and their research into communities to think about collaborating with the Global Health Center.
Yeah, I agree with that, Bill. There's a lot of people doing phenomenal work right here in our own communities. And, you know, those are the same kind of people that we like to get them involved in global health projects, because it's this bi-directional idea that we learn in one place and apply it on the other and vice versa. So we learn, it's a bi-directional learning process. And we'd love to work with all of you who are doing local work to see how it can be done in a global scale.
Victoria, you know, you have this incredibly strong focus in cardiovascular disease, which is really important and wonderful. But I would also encourage people from every division to get engaged with facilitation science and global health, because the burden of, you know, multiple comorbidities is quite extensive. And I know you're super willing to mentor people from endocrine and renal, rheumatology, and multiple divisions. So it's not just cardiovascular.
Absolutely, Vicky.
We all love the heart.
Yes,
Here,
of course. 100% in agreement, Vicky. We have started with cardiology because we feel, well, first I'm a cardiologist, and second, because it's the gorilla in the room, right? So it's the largest cause of morbidity and mortality. But we are also working with others. You know, we recently recruited Thomas O'Denny, who's actually working within a few weeks of starting. It's working on a U54 grant application with Kenya, and it's going to be very successful. And we want to replicate that model with many, many other people from all divisions and departments. So yes. And thank you for your support.
If there are no further questions, I think we can bring Grand Rounds to a close. And I want to thank everybody for their attention, and thank Victor in particular for a wonderful presentation.
Thank you very much. Thank you. Appreciate it.
Nice job. Really nice job.
Yeah, thank you.